Thank you. Next question. Can you explain how starvation ketosis can cause elevated blood sugar levels?
Yes. So this is, I'm going to explain it in a non-technical way, because this is the way I explain it to my patients, even if it isn't perfect. I explain that baby is growing 24 hours per day, and if they go too long without food, their blood sugar drops too low, so the emergency lights go on, and their body has some stored up glucose in case of emergencies, so their brain and the baby can get enough glucose. And since the body doesn't know the next time you're going to eat, it'll release a little too much glucose, and it leads to a high blood sugar in the morning. In terms of the ketones, we don't measure urinary ketones, and there's some explanation of urinary ketones in the guidelines for care that I suggest reading, because the urinary ketones aren't always reflective of blood ketone levels, so there's some questions on the usefulness of measuring them. We will measure urinary ketones if we suspect a woman is kind of starving herself to get her blood sugar under control. For the very large ladies we have who are eating a lot less food than they normally would, they're probably going to be in mild ketosis, just naturally. And if we were to try to keep them out of ketosis, they would be eating a lot of calories. Remember, this fat they have stored up is from eating excessive amounts for a long period of time. So if they're not going to be gaining much weight during pregnancy, there's going to be some ketosis going on, some fat burning going on, and that's not necessarily a bad thing. That's just my take on it, but I suggest looking at the guidelines for care for more information on ketosis.
Thank you. Okay, next question. Dr. Jovanovic states that there is no risk of ketosis affecting the baby and goes down to very little or no carbs at breakfast and some meals. What are your thoughts on this?
Yep. Well, she's actually right. We don't have any research to tell us that 130 grams is the minimum amount required, but like a lot of things with pregnancy, when we don't have studies to prove safety, we kind of err on the side of caution. So we just follow the general 130 grams minimum first trimester as the same as the general population. Are there other people who do great on low carbohydrate diets? Yeah, and I'll say I do have some women who, if they weren't to go below that 175 grams of carbs, they'd be on insulin. So my preference is to decrease their carbohydrates a little bit if it can give them glycemic control and prevent them from needing insulin.
Thank you. You mentioned 1.1 gram of protein per kilogram. Is that pre-pregnancy weight or current weight?
Pre-pregnancy weight. All the calculations are based on pre-pregnancy weight.
Thank you.
So for calories as well.
We have a comment about a doctor's note for international flights. Often the insulin bottle will have the client's name on it and it is sufficient. However, it is better to carry a doctor's note regarding your diagnosis just in case. So that just answered the question about international flights.
Yep.
Have any research or references for the stevia being safe?
Yes, and they are within the guidelines for care. I don't have them immediately accessible to me, but we can pull those up.
Okay.
I believe if you just search stevia on the FDA website, it will discuss it.
Okay.
But I was on the team responsible for including stevia as a safe sweetener, so I know we have the references for that. I just don't have them available in front of me right now.
Okay. We have another comment. The comment on the protein group is that the protein group is not the only source of proteins. Milk and yogurt are other great sources to help one reach the 71 grams per day. So that was just a little added.
Yes, there's little bits of protein in almost everything. Even if women are eating a lot of non-starchy green vegetables, they can get a significant amount of protein. And the challenge with gestational diabetes is getting them enough protein without going beyond their carbohydrate limits at the meals. That's the challenge. I try to do it through real food as much as possible. I usually don't even recommend protein powders or protein supplements unless they ask me about it. Yeah. But yeah, she's right.
And we have somebody who's agreeing with you on the not necessary, the 175 grams not being necessary for shorter women. She states, or he states, I'm sorry, I'm assuming here. My understanding is that the average carbohydrate requirement for second and third trimester is 135 grams, but that the 175 is considered adequate for 98% of pregnant women. So I tell my patients that 175 may not be necessary for shorter women or less active women.
Yeah. Yeah, usually the meal plan, I don't really like meal plans, but I just give them out as part of our teaching and meal planning, and the first class they have with me, I think has like maybe 150 grams of carbs in it, especially since a lot of women I'm seeing are first trimester. I just want to point out, though, most ladies are consuming so many carbohydrates. I mean, if you look at the general nutrition guidelines of 300 grams of carbohydrates a day, for a lot of people going to 150 is like already a huge change. Some women may need to go a little bit lower, and I think that's fine. I also want to point out something about the short stature. I really wish the BMI tables and the weight gain, prenatal weight gain, just as an aside, I wish those had some, I wish they were customized per height. I mean, we kind of do that on our own in the clinic, but say you have a woman who is, I'll use the 57 inches tall again, under 5 feet, and she's normal weight. I mean, 25 to 35 pounds on her is a lot compared to a woman who is 5'9" and normal weight. So sometimes we'll go a little lower on these weight gain guidelines because it just doesn't make sense for such a tiny woman to gain 30 pounds. And if she does, if we already know she has gestational diabetes and she gains that amount of weight, you bet she's going to be on insulin. Anyways, that's just my opinion.
Thank you. How do you balance the adequacy of the diet with restricting carbohydrates to less than 130 per day?
Well, a lot of the micronutrients they can get from non-starchy green vegetables. Of course, proteins and fats are easy in that regard. They're already relatively limited on fruits in the guidelines that we have set up of only 2 servings per day. And honestly, as long as their carbohydrates are coming from whole food sources like beans and legumes and whole wheat bread and whole grain oats, it's not very hard at all. A lot of times the excessive carbohydrates are coming from sweetened drinks and refined white flour anyways, which we all agree aren't good for the patient and aren't providing much nutrition for the baby.
Thank you. Steps to take, the CPSP program handouts do set a heart rate. Don't exceed 140 beats per minute. Do you not agree with this?
I wasn't aware that they have a heart rate on there, and the research that I've read, they hadn't set one. Maybe it was that they hadn't, I don't know, they hadn't set one because there was no agreement. The idea was that when they had done studies on, it's essentially if a woman is exercising too hard, there's always this idea that there's a risk a baby will be deprived of oxygen because it's preferentially going to the mother's muscles. For gestational diabetes, this isn't usually a worry because the women I'm seeing aren't highly active to begin with. But for elite athletes, they've found that there can be some fetal distress when women are exercising hard and their heart rate is actually below those thresholds, you know, at a normal heart rate, because she's so physically fit that her heart rate is naturally pretty low. So you can't use heart rate as an effective measure of excursions in exercise, of difficulty of exercise, of your limits in exercise, is my understanding. So I don't know. I don't disagree with that. I just haven't read that they've set one in other research. So that's new to me.
Thank you. Okay. Now, if you could just go over the prenatal nutrition needs and then the next slide.
Okay. Well, essentially, this just gives you an overview of what we recommend. That the first trimester, they don't need any more calories, and in the second and third, they need a little more. The exact calculation for calorie needs are in the CDAP Sweet Success Guidelines for Care, so you can look up those. The protein calculation is very simple. It's based on kilograms of preconception weight, and the carbohydrates, which we already discussed with a little extra discussion at the end, and I think that covers that. For obese or overweight women, we recommend just not going any lower than 1,800 calories so we don't restrict their intake of micronutrients or cause a small for gestational age baby or intrauterine growth restriction. So we just try not to go below 1,800 calories even if our calculations are telling us otherwise.
Thank you. Let's see, this would be the next one. So you just talked about this one.
Yeah.
And I do have one more question that just came in. It says, I think you said it's okay to decrease the recommended number of carbohydrates to avoid starting insulin. How low can they go?
How low can they go? Well, if you ask, you know, Lois Jovanovic, they can go as low as they need to go. How low have I gone before? Well, it's kind of hard to say because we all know how inconsistent record keeping is among our patients. So when they've given me their food records, how do I know that they're actually measuring out their rice or their beans? Or how do I know their bread is, you know, 15 grams per slice and not 22 or not 12? It's really hard to know. I try to make sure that there is some carbohydrates at every meal and snack so they're not having low blood sugar. That's my preference. We talk more in terms of servings of carbohydrates rather than grams of carbohydrates, so I just use the usual ADA exchange list of 15 grams of carbs per serving. I might have them cut a serving of carbs from their lunch or dinner. Sometimes they'll need to do only 15 grams of carbs at their nighttime snack or a little less so they don't have high fasting blood sugar. It's hard for me to give a specific gram recommendation. At the very least, if you're really concerned they're not getting enough carbohydrates, you could start counting the minimal carbohydrates that's found in the non-starchy vegetables. I normally don't even bother. It's usually pretty obvious if they need insulin or not. And if they need insulin, it's not a bad thing, and it doesn't mean they have failed. So I don't want to reduce their carbs so low that they feel like they're starving. So if they need insulin, they need insulin, but I'm willing to give them a little wiggle room in trying to reduce carbs for maybe, depending on their blood sugars, a week or so and see how they do.
Thank you so much. That was our last question.